This presentation summarises the key concepts contained within the operational patient care pathway. This concept is a holistic description of the way in which the Defence Medical Services will deliver health service support to the defence population at risk in the future. It supersedes Edition 1 of this concept and will be incorporated into the future hybrid NATO-UK Joint Allied Medical Support Doctrine. Ideally, you should have read Edition 2 of the Operational Patient Care Pathway contained in Joint Service Publication 950 Medical Policy, Leaflet 1-4-1 before this presentation. However, if you've not, it's available on the World Wide Web at the link on this slide. Clinical care for combat trauma patients has been transformed over the decade that has seen highly challenging operations in Iraq and Afghanistan. The UK Defence Medical Services are now widely acknowledged to be the international leaders in this field. Incremental improvements in the system of care have led to a significant number of unexpected survivors compared to the performance of the civilian trauma systems. The operational patient care pathway set out in this presentation provides a series of unifying concepts that articulate the clinical requirements for the UK military health service support system on operations, including the system of clinical care for the medical or non-trauma patient as well as trauma care, and in regard to the specific challenges faced by the chemical, biological, radiological and nuclear threat. The operational patient care pathway is described in 5 sections in this presentation. It builds upon a concept for a unified emergency care system published in 1999 and maximises existing doctrine. It utilises imagery, mnemonics and other aids to learning that capture the key clinical and medical operational concepts to be taught to all members of the Defence Medical Services. The context describes the healthcare cycle, which summarises the relationships between medical operations and operational capability to firm-based medical activity and capability. It also describes the chain of care that defines the clinical outcomes required for Defence Medical Services operations and capability. The duty of care, as defined in the Defence Strategic Direction, is reproduced in this section. The final element is a statement on standards of clinical healthcare. The operational patient care pathway provides a single framework for medical capabilities and clinical activities within defence medical operations and capability. It is underpinned by definitions for the defence population at risk, the all hazards environment, and the 10 capabilities of military healthcare. The operational patient care pathway defines major incident management and the primary survey because these are taught to every member of the Defence Medical Services. Medical incident management describes the approach taken by the Defence Medical Services to manage casualties at the scene of an incident. The primary survey is the initial approach for the assessment and administration of life-saving interventions to the operational casualty. This presentation will close by highlighting areas that need further refinement. The presentation will not cover the section on medical reports and returns contained in the Operational Patient Care Pathway leaflet, as this section is specifically aimed at medical operations and plans staff. So we will start by examining the 2 concepts that set out the context for the Operational Patient Care Pathway. The first concept is the healthcare cycle. This is the patient-centred provision of health service support to the defence population at risk by the Defence Medical Services throughout their career. It places the defence population at risk at the centre of our business. Defence medical operations and capability are those activities carried out by medical force elements in order to provide health service support to the defence population at risk deployed on operations. Medical force elements are force generated by the service commands and are controlled by the Chief of Joint Operations through the operational chain of command. The Surgeon General is the defence authority for the whole healthcare cycle and is responsible for assuring the quality of healthcare delivered to service and other entitled personnel. The Defence Medical Operations and Capability is shaded in purple. Prior to and on deployment, the Defence Medical Services supports the provision of force health protection measures to service personnel from the defence population at risk. Service personnel who become operational patients are supported by the 10 instruments of military healthcare and, if necessary, are medically evacuated from the theatre of operations. Patients are accepted into the National Health Service under the reception arrangements for military patients and are usually admitted to the clinical unit of the Royal Centre for Defence Medicine. Those that require specialist rehabilitation are transferred to the Defence Medical Rehabilitation Centre. Those requiring less specialised rehabilitation will be managed at the regional rehabilitation units within the Defence Primary Healthcare Command organisation. In all cases, after completion of care within the Defence Medical Operations and Capability, service personnel return to Defence Population at Risk under the purview of the Defence Medical Services firm-based medical activities and capability. Administration is undertaken by their own unit, or through personnel recovery units or centres that form the Defence Recovery Capability. Firm-based clinical services are provided on a joint basis through the Defence Primary Healthcare Command, Defence Dental Services and Defence Healthcare Commissioning. The chain of care is the description of the clinical outcomes required from the operational patient care pathway. The chain of command and the Defence Medical Services collectively contribute to the application of health protection measures to the defence population at risk as described in the Defence Health Strategy. If health protection fails, operational patients become sick or injured. First aid measures are essential to save life, limb and eyesight. The training of all personnel in essential first aid and a proportion of military personnel in extended first aid is the responsibility of the chain of command, supported by technical training assistance from the Defence Medical Services. The Defence Medical Services trains clinical personnel to provide pre-hospital emergency care in order to take clinical responsibility for non-professional healthcare providers and institute life-saving measures. Progressive resuscitation extends these emergency measures from the pre-hospital environment to the capabilities of deployed hospital care. As the patient stabilises, the clinical focus shifts to restoring physiological function through clinical care and medical evacuation. Once the patient is physiologically stable, care shifts to promote healing through wound care, nutrition and psychological support. Finally, the patient leaves hospital care. The Defence Medical Services and the chain of command support the patient in rehabilitation and return to physical, psychological and social function, enabling them to return to duty or prepare for discharge from service on medical grounds. The size of the ovals is indicative of the scale of organisational effort required to provide the clinical outcomes at each stage in the chain of care. So let's move on to the operational patient care pathway itself. It is the unified approach for clinical care to all operational patients arising from the defence population at risk that have been exposed to the all-hazards environment on operations. The application of the operational patient care pathway is informed by the 10-1-2+2 medical planning guideline. It encompasses the 10 instruments of military healthcare and underpinning clinical concepts. The operational patient care pathway comprises these core definitions. They will be highlighted as we go through the presentation. You should refer to the Joint Service Publication 950 policy leaflet for the specific wording of each of these. The All Hazards Environment is the list of potential hazards to the defence population at risk summarised by the mnemonic CBRN E3T. The defence population at risk may be at risk from a range of potential hazards on military operations. A confirmed hazard is defined as a threat for a specific operation. This expands on the CBRNE acronym widely used in the civilian world for major incident planning and emphasises the importance of disease and non-battle injury as the primary cause of health-related restrictions to human performance on operations. Defence medical operational capability must be capable of supporting military operations whilst exposed to this all-hazards environment and be capable of providing clinical care to patients suffering from the consequences of exposure to one or more of these threats. The Force Health Protection Estimate for a specific operation will determine the CBRN E3T threats to the defence population at risks defined in the medical rules of eligibility. This will cover the impact of these threats across the three domains of health: physical, psychological, and social. The CBRN E3T hazards are: chemical covers conventional chemical agent threats plus toxic industrial chemicals, riot control agents, and chemical hazards derived from pharmaceuticals. Biological covers live organisms, toxins, and biological hazards deliberately employed to harm the defence population at risk. Radiological covers material or events that release ionizing, including alpha, beta, gamma radiation and neutrons, and non-ionizing radiation, including directed energy. Nuclear covers weapons or events that result in nuclear fission or fusion reactions. Explosive and ballistic covers all consequences of explosive activity on human bodies, including gunshot wounds, indirect fire, improvised explosive devices, shells, and bombs. Environmental covers environmental conditions likely to cause harm, such as heat, cold, and altitude. Endemic covers infections from diseases, biological agents of operational significance that pose a hazard to the health of the defence population at risk that are not deliberately released. Trauma covers the trauma element of non-battle injury threats to health in order to complement other measures. We will now spend some time going through each individual component shown on the slide and discuss subordinate clinical concepts in later slides. The term operational patient is an individual from the defence population at risk with physical, psychological, or social ill health who requires clinical care from the Defence Medical Services on deployed operations encompassing battle casualties or disease and non-battle injuries. The definition has specifically been selected, vice combat casualty, to wind the focus from care of trauma patients to holistic care of all patients who require health service support on operations. The term casualty is an operational patient prior to their admission to a medical treatment facility. Thus, the commonly used terms casualty collection point, casualty decontamination area, and casualty clearing station are retained. The operational patient care pathway combines concepts from incident management for trauma patients and CBRN patients, links these to the clinical capabilities described in the 10 instruments of military healthcare, and illustrates the continuous, seamless, escalatory increase in clinical care provided to the operational patient. There is deliberate overlap in the boundaries between pre-hospital emergency care and progressive resuscitation in order to provide the maximum doctrinal freedom to medical operational planners in the specific employment of clinical personnel and equipment in medical units. The key to successful delivery of the operational care pathway is the continuous and incremental provision of clinical care to meet the needs of the operational patient independent of organisational boundaries. There are two zones of care. The hot zone is a non-permissive environment representing an immediate threat to personnel from direct fire or a known environmental threat. Clinical care is limited to care under fire, covering only those techniques necessary to provide immediate life-saving interventions whilst the patient is being extracted. This is likely to be provided as self-administered or buddy-buddy first aid. The warm zone is a semi-permissive environment representing a specific secondary threat to personnel from indirect fire or other CBRN E3T threat. There is not likely to be a demonstrable hard edge to the warm zone. Clinical care is described as tactical field care, covering those interventions necessary to save or stabilize life and prepare the patient for medical evacuation. The casualty collection point is likely to be within the warm zone. Conceptually, the clean-dirty line for the handover of casualties from the casualty decontamination area is likely to be the edge of the warm zone, with the casualty clearing station probably outside the warm zone. The area outside the warm zone has not been explicitly labelled. There may be potential threats to health service support system, but these are not sufficiently specific to extend the radius of the warm zone. Care of the casualty starts at the point of injury in the hot zone. The casualty receives care under fire during extraction from the hot zone, which extends to the remainder of the tactical field care capability. Casualties are amalgamated at the casualty collection point. After initial triage, casualties are transported to a casualty decontamination area, where they are sanitized to remove any threats to their health or that of their carers. If it is not possible to medically evacuate them directly to deployed hospital care, casualties are transported to a casualty clearing station for emergency team care, pending medical evacuation to deployed hospital care. Deployed hospital care may be organised into echelons of care, illustrated schematically as forward and rear. The pre-hospital care environment encompasses all aspects of health service support forward of deployed hospital care. It includes core functions of primary health care, pre-hospital emergency care, forward medical evacuation and forced health protection, enabled by medical logistics and medical command control communication, computers and information, all organised as an agile, layered networked healthcare system, configured to ensure the specific healthcare needs of the defence population at risk are supported and accessed within accepted timelines. Prolonged field care is provided to casualties if there is likely to be a delay in meeting the 10-1-2+2 medical planning guideline. The movement of operational patients between deployed hospital care facilities is tactical evacuation, and their movement from the joint operational area to Role 4 in the firm base is strategic evacuation. The Defence Medical Services Inspector General is responsible for Defence Medical Services assurance of the operational patient care pathway under the direction of the Surgeon General. The 10-1-2+2 medical planning guideline is the guideline for the location of clinical capabilities by time in the operational patient care pathway. It is the default for medical operational planning, and any excursion from this guideline must be owned by the operational commander. The speed and quality of medical care can reduce the mortality and morbidity of operational patients. The ideal is always to deliver expert care as soon as possible after wounding. Evacuation should be to the most appropriate facility for the treatment of the casualty, noting the most appropriate facility may not necessarily be the closest. All time delays carry clinical risk for patients. It is for commanders, advised by their medical staff, to balance these risks with operational and other factors and to determine whether or not the risks are acceptable. To achieve this in practice, the 10-1-2+2 medical planning guideline informs decision-making regarding the configuration and location of the medical evacuation and treatment assets needed to provide appropriate medical coverage to the supported force. Whilst primarily expressed as time for the trauma patient, the principles apply to the non-trauma patient also. The benchmark in civilian practice is rapid access within 8 minutes and hospital-based surgery within 1 hour of injury. Where the civilian standard cannot be met, evidence from accumulated experience in Iraq, Afghanistan, and earlier campaigns shows that there are 3 key timelines from point of injury to first surgical intervention and a 4th for in-theatre specialist clinical care. The first phase of the medical planning guideline, 10.1.2, is a cumulative time. The +2 sets the location by time for in-theatre surgery and enhanced diagnostics within the joint operational area. Please take a moment to read each of the definitions on this slide. The 10 instruments of military healthcare is a unified description of the medical capabilities required to be considered to generate and deliver effective health service support on operations. The Defence Medical Services must be able to force generate medical force elements against these instruments, mission tailored to the scale and complexity of a specific operation. Medical force elements from environmental components will be integrated into a single health service support plan for the joint force. This may involve the use of multinational contributions to the health service support plan. The 10 instruments of military healthcare incorporate the 7 operational capabilities of care and include medical command, control, communication, computers, and information. These are the authority, processes, communications, architecture, and information management resources employed in managing the Defence Medical Services operations and capability system. Medical command, control, communication, computers, and information is covered in more detail in the joint concept paper titled Health Service Support to the Joint Operational Area. Force health protection is defined as the conservation of the fighting potential of a force so that it is healthy, fully combat effective, and can be applied at the decisive time and place. It consists of actions taken to counter the debilitating effects of environment, disease, and selected special weapon systems through preventative measures for personnel, systems, and operational formations. It considers force preparation measures, environmental health advice, in-theatre preventative measures, post-exposure measures, and rehabilitation of the force. Force health protection must include competent medical advice in force health protection for CBRN threats. Force health protection incorporates medical intelligence. Medical intelligence is intelligence derived from medical, bioscientific, epidemiological, environmental, and other information related to human or animal health. Pre-hospital emergency care is the continuum of emergency care provided to a casualty by individuals or teams, from first clinical intervention at point of injury through to reception of the operational patient at deployed hospital care. The primary clinical output within pre-hospital emergency care is progressive resuscitation. Primary health care is those comprehensive community medical services that contribute to the protection, maintenance, and restoration of health of the defence population at risk. Deployed hospital care is those clinical services provided by clinical personnel usually employed within hospitals. Access to deployed hospital care within the 10.1.2+2 medical planning guideline is an essential component of the operational patient care pathway. Where time and/or distance precludes provision by a single deployed hospital care facility, deployed hospital care may be echeloned into deployed hospital care facilities. Deployed hospital care forward facilities are likely to be mobile to enable the provision of progressive resuscitation and damage control surgery within 2 hours. Deployed hospital care rear facilities are likely to be static and focus on the provision of in-theatre surgery and enhanced diagnostics. Medical evacuation is the movement of operational patients under medical supervision in a designated transport platform equipped for role. Medical evacuation is controlled by a Patient Evacuation Coordination Cell, or PEC, that operates under the authority of the battle space owner to ensure that medical evacuation platforms conform to the tactical environment. The Patient Evacuation Coordination Cell is responsible for ensuring that the right patient is collected from the right pickup point, transported to the right destination, in the right platform, with the right medical escort, in the right time. There are 3 categories of medical evacuation. Forward medical evacuation is the movement of casualties in a designated vehicle with medical escorts from point of injury to the first deployed hospital care facility, including to and from the casualty clearing station. The movement of casualties in a non-designated vehicle without a medical escort is termed as casualty evacuation, or CASEVAC. Tactical medical evacuation is the intra-theatre movement of patients between deployed hospital care facilities. Strategic medical evacuation is the movement of patients from the theatre of operations, usually to Role 4. Medical logistics is the process of procurement, storage, movement, distribution, maintenance, and disposition of medical material and pharmaceuticals, including blood components, and medical gases, in order to provide effective medical support and the application of this process in planning and implementation. Firm base includes those capabilities that provide health service support to the defence population at risk. Within the firm base, less the Royal Centre for Defence Medicine and Defence Medical Rehabilitation Centre, which are Role 4 operational. The firm base plays a vital role in maintaining business as usual, including the force generation of personnel to deploy in operations, maintaining force elements at readiness, providing a manning and training management for commitments, and supporting resilience within the UK. The military medical contribution to security and stabilisation is those areas where health service support can play a definitive role in delivering operational effect in addition to the operational patient care pathway. These include humanitarian assistance and disaster relief operations, security sector reform, and civilian health sector development. Medical force elements may be required to provide capability to support the delivery in effect in all of these areas. Research and innovation is the process of investigation and study that is used to deliver concepts and practical applications that can contribute to the sustainment of health on operations. This is delivered by Medical Directorate and is supported through the operational healthcare cycle. Perpetual research and innovation enables the delivery of world-leading health service support. As stated earlier, progressive resuscitation incorporates damage control resuscitation and is the core output from pre-hospital emergency care. Progressive resuscitation is the use of multiple techniques drawn from technical and organisational advances in clinical care for the critically ill or injured patient. Progressive resuscitation incorporates damage control resuscitation for the care of the trauma patient. Damage control resuscitation is defined as a systematic approach to major trauma combining the catastrophic bleeding, airway, breathing, circulation or CABC paradigm with a series of clinical techniques from point of wounding to definitive treatment in order to minimise blood loss, maximise tissue oxygenation and optimise outcome. Pre-hospital emergency care comprises the following 4 clinical phases. Tactical field care is those interventions necessary to save, stabilise life and prepare the casualty for medical evacuation. It can be provided by any extended trained individual, incorporating team medic or other authorised extended qualifications, plus all DMS clinical personnel. Tactical field care incorporates care under fire. Care under fire is those techniques necessary to provide immediate life-saving interventions to the casualty in the hot zone while the patient is being extracted. The requirement for care under fire is the basis of all first aid training taught to all members of the armed forces. Enhanced field care is that emergency clinical care provided by a clinical team made possible by a more permissive environment using battlefield advanced trauma life support and CBRN emergency medical treatment and other progressive clinical techniques as described in Joint Services Publication 999, Clinical Guidelines for Operations. Prolonged field care is those additional techniques that sustain the casualty if the 10-1-2+2 medical planning guideline is likely to be exceeded. Deployed hospital care covers the following specific clinical concepts. Damage control surgery comprises of a range of surgical interventions targeted at halting deterioration of the patient's physiological condition rather than attempting definitive restoration of function. It is required when the physiological derangement is so severe that it is unlikely that the patient would survive prolonged surgery. It aims to rapidly control hemorrhage whilst maintaining perfusion of essential tissues and organs and limit ongoing contamination. It is integral to progressive resuscitation and is an interdisciplinary effort rather than solely a surgical challenge. In particular, damage control surgery will require critical care support either at the medical treatment facility or at an alternative medical treatment facility accessible by critical care air support team level tactical evacuation within an appropriate timeline. Damage control surgery should be followed later on by in-theatre surgery, which is delayed until the various physiological and other relative parameters have been restored to as close as normal as possible. It can only occur within a deployed hospital care unit. This usually requires a combination of general and orthopaedic surgery and should include burns and plastic surgery wherever possible. In-theatre surgery may consist of several surgical procedures spread over a period of time and may require the movement of patients between medical treatment facilities within a theatre of operations. The requirement for in-theatre surgery is dictated by both the patient's condition and operational circumstances. The factors to be considered when considering a patient's condition include the requirement to halt physiological deterioration and adequate debridement, anatomical repair, and therapeutic intervention to allow safe evacuation to a definitive care facility. Operational factors may include extended evacuation timelines that demand further surgical interventions for patient safety. Appropriate definitive surgery to permit deliberate retention in theatre and appropriate definitive surgery for patients ineligible for evacuation out of theatre may also be required. Enhanced diagnostics are those clinical support activities, including CT scan if not available as part of damage control surgery, interventional radiology, and specialist laboratory support, including biochemistry, hematology, and microbiology testing, that enable clinical therapies to address the specific cause of injury or illness that are additional to generic stabilizing therapies. Mission-specific clinical capabilities are those clinical and clinical support capabilities that are mission-tailored for each specific operation dependent on the CBRN, E3T, and medical rules of eligibility. Medical incident management is included within the operational patient care pathway because it is the core tactical technique employed by the Defence Medical Services. It is essential that a common approach is taught from Phase 2 training to defence medics through to specialist training for consultants and is absolutely understood by medical planners. Medical incident management is a common approach to the response from the Defence Medical Services to an incident involving live casualties. A major medical incident is an incident where the number, severity, or type of live casualties, or by its location, requires extraordinary resources. A major medical incident is declared bottom-up, with each level of command considering whether it also needs to make the same declaration. A mass casualty incident is a major medical incident which, despite the use of extraordinary measures, has or will result in an overwhelming of the available medical capability and/or capacity. This is declared top-down by the theatre commander medical and is cascaded down the chain of command. In a mass casualty situation, the theatre commander medical may recommend to the commander at the operational level that the T4 expectant triage category is initiated in order to focus the medical effort on the best outcome for the maximum numbers of survivors. The principles of medical incident management are covered by the mnemonic C-SCATTER, which builds on the mnemonic C-SCAT in common use for medical major incident planning. Command and control is the establishment of medical advice to the incident commander and control over the medical response to the incident using medical command, control, communication computers, and information capabilities. Safety is the assessment of the CBRN E3T threat to the safety of the first responders, the scene, and the casualty. It will almost invariably involve the wearing of individual protective equipment. Communications is the provision of the communication architecture that enables all organisations to effectively respond to a medical incident. Assess is the overall evaluation of the scene to determine the cause of the incident, the number and severity of operational patients, and is the initial medical response to the incident. Triage is the technique used to determine initial treatment priority for 2 or more operational patients and for assessing the priority for further treatment or medical evacuation after primary survey. Treatment is the application of pre-hospital emergency care to the care of casualties. It consists of primary survey, progressive resuscitation, secondary survey, and definitive care. Transport is the application of medical evacuation to clear the scene of operational patients. Exploit is the collection and retention of evidence, including medical evidence, to allow the chain of command to exploit the response to the incident. Recover is the restoration of the response system to the pre-incident state, plus the immediate after-action analysis to learn lessons from the incident itself. The primary survey is a structured approach to the initial assessment and management of the operational patient at each stage of the operational patient care pathway. It comprises the following steps. Catastrophic compressible bleeding. This is bleeding that is immediately life-threatening without intervention and is amenable to control by use of direct pressure, a tourniquet, or bleeding control interventions. Airway, with C-spine control management and antidotes, is the assessment of the airway plus clinical interventions required to maintain the airway and the assessment and administration of life-saving antidotes to absorbed toxic agents, mainly CBRN threats. Breathing is the assessment of adequacy of breathing and support to oxygen absorption. Circulation is the assessment of adequacy of circulation and support to tissue oxygenation, including progressive resuscitation. Disability is the assessment of the head-injured patient to establish a baseline of neurological function. Decontamination is the removal of the CBRN E3T threat in order to stop further absorption of external agents exposed to treat wounds and to remove any hazard to personnel in the medical evacuation system. Exposure is the removal of sufficient clothing to enable full assessment of the operational patient. Environment is the packing of the operational patient in order to protect them from the external environment during medical evacuation. Extremities is the examination of the operational patient's limbs for unassessed injuries, and evacuation is the arrangement of medical evacuation for the operational patient to the next phase of their clinical care. So this completes the formal briefing on the operational patient care pathway. There are, however, some key underpinning concepts that need further refinement. The 10-1-2+2 medical planning guideline is subject to a review by DSTL. The definition of triage categories is currently being reviewed in order to ensure that they are fit for future contingency. And finally, we need to continue to capture the medical lessons in the firm base on exercises and operations to ensure that this concept continues to develop. 5 areas were covered during this presentation. The context was provided, including a description of the healthcare cycle and the chain of care. The operational patient care pathway was examined in some detail, covering both the key capabilities and key clinical concepts contained in the unifying diagram. The key elements of medical incident management and the primary survey were discussed before closing by highlighting areas that need further refinement. This concludes the presentation on the operational patient care pathway.